Thank you very much for joining us for this afternoon's excellent session. You hope that you'll find today's program very chock full of information that will help you to manage your patients and help you to stimulate more interest in learning about the new approaches to dealing with complex problems within our patients. Again, just a reminder, you have to be seated at a table that has an audience response pad, since there will be audience response opportunities within our program. Today we've assembled an excellent panel for you, and I will be introducing each of them individually as we get ready to present their program. At the outset, I want to declare that I have no conflicts to disclose. As a matter of fact, I don't have much of anything to disclose, so if you want to make a loan, let me know. We have three excellent presenters. We'll be started by Dr. Polk, and then we will be followed by Dr. Kingslow and then Dr. Mahari. But as we start today's program, we're going to start with a pretest. So if you don't mind, if you grab your audience response pads, and we'll begin our pretest. A 55-year-old man has a 2-year history of fatigue and daytime sleepiness. He has dyspnea on exertion for the past year, especially after walking upstairs or an incline. He does not smoke cigarettes. He has hypertension and is taking only losartan. On physical examination, vital signs are normal. He is obese with a BMI of 38. He has a short, thick neck, circumference 20 inches. There is increased intensity of P2. Chest radiograph is normal. Pulmonary function tests are normal. Transthoracic echocardiography shows evidence of right ventricular hypertrophy and mild pulmonary hypertension. A lung ventilation perfusion is normal. Which of the following is the most appropriate management for this patient? Number 1, lung transplantation. Number 2, polysomnography. Number 3, right heart catheterization. Number 4, nocturnal continuous positive airway pressures, or CPAP. And number 5, sildenafil. Please vote now.
Because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth.
Okay. Oh, we've got a nice array of results here. Opportunities. Okay. Next question, please. A 32-year-old nursing student has a 2-year history of progressive dyspnea. She was treated for asthma with albuterol inhaler, but her symptoms continued to worsen. Her medical history is otherwise normal. She is a non-smoker. Currently, she is not taking any medications. On physical examination, vital signs are normal. BMI is normal at 25. P2 is prominent. A grade 1 to 2 over 6 holosystolic murmur that increases with inspiration is heard, best along the left lower sternal border. Workup, including serologic and lab studies, as listed here, were normal. Chest radiographs reveal prominent central pulmonary arteries, otherwise clear lungs. Pulmonary function tests revealed a mildly reduced DLCO without evidence of airway obstruction or decreased lung volumes. Transthoracic echocardiogram shows normal left ventricular size and function, a dilated right ventricle, and an estimated right ventricular systolic pressure of 45 millimeters of mercury. Lung ventilation perfusion scan is normal. Which of the following is the most appropriate diagnostic test to perform? Number 1, pulmonary angiography. Number 2, sleep study. Number 3, transesophageal echocardiography. Number 4, right heart catheterization. Number 5, high resolution chest CT. Okay? So please vote now. A nice spread of results again. Excellent. Today, as I shared with you, we have an excellent opportunity to really have some wonderful presentations. Our first presenter will be Dr. Octavius Polk. Dr. Polk serves as Clinical Assistant Professor of Medicine at Howard University College of Medicine. He is also in private practice in Washington, D.C. Dr. Polk received his medical degree from the University of Mississippi School of Medicine. He completed a residency program in internal medicine and a fellowship in pulmonary diseases at Howard University in Washington, D.C. Dr. Polk completed a critical care medicine fellowship at Maryland Institute of Emergency Medicine and Medical Systems in Baltimore, Maryland. He has really focused on teaching in the community-based setting and has been recognized for his effective teaching of residents. It's my pleasure to present to you Dr. Polk.
Well, good afternoon, everyone. Greetings from Washington, D.C. and the Howard University community. I always want to give a shout out to my fellow comrades from Mississippi before I start. Thanks to the National Medical Association and the Family Practice Session for allowing us to participate in this educational experience. I'll be followed by two outstanding clinicians who will discuss this. I hope to provide you with information on the new classification for pulmonary hypertension. As I told one of my residents and fellows a few months ago, that pulmonary hypertension is more than just sildenafil. So hopefully you'll learn that as well. I have no disclosures for you. My objectives today are to define the World Health Organization classification of pulmonary hypertension. You'll be able to identify the signs and symptoms that suggest the diagnosis of pulmonary hypertension. Also, you'll be able to describe the appropriate workup of a patient with possible pulmonary hypertension. So this is a good conceptual diagram of the vascular pressures within the systemic and pulmonary circulations. As you can see, there's a big difference between the systemic and the pulmonary circulations. When you look at the pulmonary circulation, it has low resistance, a high capacitance, and pressures are about 15 to 20% less than that of the systemic circulation. These are the normal pressures that we normally see at right heart catheterizations in patients who are catheterized, with a mean PA pressure of about 9 to 18 millimeters of mercury. Now, what is the current definition of pulmonary hypertension? By the current definition, based on data from the Nice, France Symposium on Pulmonary Hypertension, it is represented by a mean pulmonary pressure of about 25 millimeters of mercury, greater than or equal to 25 millimeters of mercury. Based on pulmonary hypertension, they are divided into 5 categories. The terms primary and secondary pulmonary hypertension are considered historical, mainly because it's confusing to the workup of the patients, and also therapeutic interventions might be confused by calling them primary or secondary. Based on the information and consensus from the 5th World Symposium on Pulmonary Hypertension from Nice, France in 2013, we now have pulmonary arterial hypertension is by definition, and there's 3 different caveats to make that definition. The first is, again, a mean pulmonary artery pressure of 25 millimeters of mercury that is greater than or equal to 25 millimeters of mercury, and without findings of left heart disease or venous hypertension with a pulmonary capillary wedge pressure, or the left ventricular and diastolic pressure of less than or equal to 15 millimeters of mercury. A new part of the definition is the pulmonary vascular resistance measured in Wood units of at least 3 or more to define pulmonary arterial hypertension. So there's a difference. Pulmonary hypertension is the broad definition of patients who have high pressures within the pulmonary circulation. We'll be focusing somewhat on pulmonary arterial hypertension in our patients, and we'll talk about that in just a minute. This is a diagram looking at the diagnostic classification, and pulmonary arterial hypertension is considered group 1. Again, it has similar, different diseases, but all have a similar pathway, and results in damage to the pulmonary circulation. The most common cause of pulmonary hypertension in this country is left heart disease, which is group 2. This can either be due to systolic dysfunction or related to what we call high pressure or diastolic dysfunction. The third process that we see is probably the next most common cause is pulmonary hypertension due to lung diseases and or chronic hypoxemia, and the most common cause of that would be COPD. The fourth one is chronic thromboembolic pulmonary hypertension, which is a potentially curable form of pulmonary hypertension. And the fifth category is pulmonary hypertension with unclear or multifactorial mechanisms. Now, when you look at the cause of arterial hypertension, and this is data from multiple pulmonary hypertension centers, almost half of the cases are related to idiopathic pulmonary arterial hypertension, and the other half is related to associated pulmonary arterial hypertension. That is from connective tissue disease, portal hypertension, drugs or toxins, HIV infection, and congenital heart disease. When you look at this further, some drugs can cause pulmonary hypertension, and this is updated again in France in 2013. The definitive causes of pulmonary hypertension include the following. They have likely drugs such as amphetamines, and possible drugs that may cause pulmonary hypertension, which include cocaine, St. John's wort. I don't know if that's still over the counter, but that can cause it. Interferon, alpha and beta, and also some chemotherapeutic agents have been implicated as causing pulmonary arterial hypertension. When we look at the prevalence and characteristics of pulmonary hypertension, it is not that a common disease. As you can see, it's about 15 per million. With associated pulmonary arterial hypertension, scleroderma is probably the most common cause of that and may occur in up to 27% of patients based on echocardiographic data. Portal pulmonary hypertension is common in cirrhosis, occurring in about 1 to 6% of patients, and up to over 5% of patients who are candidates for liver transplant may be found to have pulmonary hypertension. It's estimated that about 0.5% of HIV-positive patients will go on to develop pulmonary hypertension. When you look at chronic thromboembolic pulmonary hypertension, it occurs about a little bit less than 1% after the first PE, and as you can see here, at 3% at 1 year and 2%, almost 4% at 2 years. Sickle cell disease is another common cause of pulmonary hypertension, and Dr. Meharry will talk about that. One important aspect of why one should do thyroid function tests is that thyroid function dysfunction can cause pulmonary hypertension, but is easily treatable if you treat the thyroid disease. Worldwide, schistosomiasis is probably the most common cause of pulmonary hypertension seen in centers. When you look at into Brazilian pulmonary hypertension centers, 30% of the patients who had pulmonary arterial hypertension had evidence of schistosomiasis in their bodies. One also isolated event is that splenectomy is seen up to 12% in cases in pulmonary hypertension centers in patients who have idiopathic pulmonary hypertension. So splenectomy by itself, and why they developed that is not quite clear cut. The heritable form of pulmonary hypertension is autosomal dominant. The important part about this is that there's a mutation in the bone morphogenetic protein receptor 2, or BMR-PR2, and it is detected in about 70% of patients who have familial pulmonary hypertension. It's also seen in 20% of those patients who have idiopathic pulmonary hypertension. There's incomplete penetrance, and there's genetic anticipation. Connective tissue disease, again, it causes associated pulmonary arterial hypertension, with scleroderma being the most common cause. Almost all the other connective tissue diseases can cause pulmonary hypertension or even vasculitis. In scleroderma, pulmonary hypertension is one of the primary causes of death in patients, along with pulmonary fibrosis. It has a similar pathology to idiopathic pulmonary arterial hypertension. Therefore, therapeutic intervention is very similar in those patients, but of less benefit. Important part about CTEPH, or chronic thromboembolic pulmonary hypertension, is that in about 40 to 50% of the cases, patients do not have a previous history of acute PE and are found to have chronic thromboembolic pulmonary hypertension. In addition, the VQ scan is better suited to make the diagnosis than regular CT angio of the chest. And I've always had physicians always ask me, why do we got to get a VQ scan? And this is the main reason when we're working with patients who have pulmonary hypertension, is that the VQ scan is a much greater ability to make a diagnosis of CTEPH than the CT scan by itself. Now let's take a brief moment and talk about the pathophysiology of a pulmonary arterial hypertension. And it's related to progressive growth and vasoconstriction of the small pulmonary arteries itself. And what happens in these patients is that the adventitia, the media, and the intima are affected because of persistent elevated pulmonary pressures. Over time, what happens is that these causes damage to these areas. And what happens is you develop smooth muscle hypertrophy and early intimal thickening of the pulmonary arteries itself. At this point, the disease is probably reversible, but unfortunately, this continues to develop problems within the pulmonary arteries itself. Sometimes biomarkers such as a BNP may show or make one aware of the problems that occur in these areas. As this continues, one goes on to develop damage to the lungs, which includes smooth muscle hypertrophy, adventitial intimal proliferation, thrombosis, and plexiform lesions, which are irreversible. At this point, the patient goes on to develop decrease in the cardiac output, progressive increase in the pulmonary pressures, and ultimately right heart disease and right heart failure, and ultimately death. When we look at survival in pulmonary arterial hypertension, what we see is that the median survival from the time of diagnosis is only about 2.8 years, worse than cancer, or as bad as cancer. And over 50% of untreated patients will die within 5 years from the diagnosis. So it's a pretty fatal disease. Even with treatment, the disease tends to be worse in patients with connective tissue disorders and HIV infections, despite therapeutic interventions. So we're going to stop here, and we're going to look at a case briefly and see how this case represents what we see in clinical practice. This is a typical patient, 37-year-old woman, previously healthy, delivered a second child at 14 months, had limited exercise tolerance, had dyspnea while playing with her older children, and syncope while walking up an incline. There was also exertional lightheadedness, atypical chest pain, occasional palpitations, and lower extremity edema. Additional history revealed that she had irritable bowel disease that was diet controlled, was on no medications, had allergy to contrast dye, but no other remarkable history that could be attributed to this patient. So let's stop here and say, what are the symptoms of pulmonary hypertension? And the main symptom is progressive dyspnea, which can be a cause of a lot of other diseases. It's the initial symptom in more than half of the patients. Ultimately, 85 to 95% of patients who develop pulmonary hypertension will develop dyspnea. And 20% of the patients who present with pulmonary hypertension have had these symptoms for more than 2 years, which means it's a chronic process and has been missed by the clinician or the patient. Other symptoms include fatigue, chest pain, presyncope, syncope, lower extremity edema, or even palpitations. On physical exam, early on in the course of the disease, is predominantly unremarkable. You may not find anything on physical exam. That's what can be so perplexing to the physicians, and even us. Once they develop right heart strain and right heart failure, as we talked about, you can have elevated jugular venous pressures, parasternal lifts, a loud P2, a right-sided S3 or S4, a holosystolic murmur of tricuspid regurgitation that is exacerbated or intensified by inspiration. Once they have right heart failure, you develop peripheral edema and hepatomegaly and hepatic congestion. When you look at this algorithm, it's kind of daunting, isn't it? But because of pulmonary hypertension and its multiple causes, we have to do an extensive workup in these patients. This is a complex illness, and again, it's multiple causes. So I'm going to try to break it down a little bit, because looking at this, you would say, man, what the hell am I going to do to work these patients up? So anyway, let's start here. The EKG and the chest x-ray may be somewhat helpful by showing right bundle branch block, right heart failure, and right axis deviation. The chest x-ray, as in the previous case, you may see evidence of prominent central pulmonary arteries, peripheral hypovascularity or pruning of the pulmonary vessels, and if you look at the lateral view, you'll see right ventricular enlargement on the chest x-ray. These are suggestive findings of pulmonary hypertension, but non-specific. The other thing you can do is the best screening test that we have available is looking at the echocardiography, and one can estimate the pulmonary artery systolic pressure by looking at the tricuspid regurgitant flow velocity. By looking at that, one may be able to determine, at least suggest that the patient may have evidence of pulmonary hypertension. The other reason echocardiogram is very important is that you can look at the left side of the heart to see if there's evidence of systolic or diastolic dysfunction. In addition, you can also determine if there's valvular abnormalities or even a shunt may be present by looking at the echocardiogram. So really, this is a really key test to do in a patient when you're looking at it. Also, we want to remind you that, again, is that CTEPH, or chronic thromboembolic pulmonary hypertension, must be ruled out in your patient because this is a potentially curable disease. And so must rule it out. And sometimes, as you can see here, what you're looking at on the left or your right, my right and your left, yes. What you're looking at here is the bands and pouches on the CT scan that are depicted or suggestive of CTEPH. And this is what is seen on the pathologic specimen when you look at it. Did I go over that? Let's see. Now, to work these patients up, as we mentioned earlier, you want to do a lung VQ scan. A normal or very low probability VQ scan essentially excludes chronic pulmonary embolism as a cause of pulmonary hypertension. CTPH should be excluded even in those patients who have a diagnosis of pulmonary hypertension that you think you are aware of what it is due to, because you can have both CTEPH and a pulmonary arterial hypertension together. So a VQ scan is always recommended in the work of a patient who has pulmonary hypertension to rule out the possibility of CTEPH. In addition, the next test we would do in patients would be pulmonary function testing. That's dear to my heart. The reason we do pulmonary function testing is to look to see if the patient has some form of lung disease, such as COPD, which you would see an obstructive defect, interstitial disease, which you may see a restricted defect. In patients with isolated diffusion capacities, one looks for pulmonary vascular diseases such as pulmonary hypertension. And so in patients who have idiopathic pulmonary arterial hypertension, or CTEPH, about 20% have reduced lung volumes, not that many. About 60 to 80% though have reduction in the diffuser capacity. Of note is that the pulmonary vascular resistance does correlate fairly well with a reduction in the diffusing capacity. In addition, in scleroderma, 20% of the patients have an isolated diffusing capacity. The severity of the diffusing capacity predicts future pulmonary hypertension, and the DLCO correlates inversely with pulmonary systolic pressure, which represents pulmonary hypertension. In COPD patients, pulmonary hypertension can also be seen in these patients, but most patients have mild to moderate pulmonary hypertension, which does not require therapy. Every now and then, the patient can have severe pulmonary hypertension that's so severe it approaches that of pulmonary arterial hypertension. Now, the next thing we do are functional evaluations of patients, and the first is a 6-minute walk test. And the 6-minute walk test was found to be an independent predictor of survival in the pivotal epoprostenol study, and also predicts survival at 3 months on eprostenol, as you can see on these next couple of slides. When you look at this, what you see here is that patients who have a 6-minute walk test, who have pulmonary arterial hypertension, who have a short distance walking, their mortality is significantly higher than that of the person who's able to walk a pretty good distance. And so what we're looking at with this is a functional study and to look at it. And most series now looking at pulmonary hypertension response to therapies, we look at 6-minute walk test as a functional measurement of response to therapy, and also as a predictor of possible deterioration and mortality. This is similar to looking at the CPET study or exercise study. But again, when we look at it, the most important thing is that the 6-minute walk test is one of the few studies that represents good response to activity. It has a good predictor of response to therapy and also of mortality. Other markers that people look at are the functional capacity, the NYHA classification, the 6-minute walk test, and with the right heart cath looking at the mean right atrial pressure. And again, this summarizes what we see is that if you look at patients with a 6-minute walk, the worse the 6-minute walk, the worse the symptoms, and the worse the patient's going to do. The last one I want to talk about is obstructive sleep apnea. And in patients with symptoms of obstructive sleep apnea, polysomnography should be included in screening. In a retrospective study, 17% of patients with severe obstructive sleep apnea had mild to moderate pulmonary hypertension. And what is important in this is that when these patients are treated, they do much better. And suggestion from this is that if a patient has pulmonary hypertension associated with obstructive sleep apnea, if it's not treated, they may not respond as adequately to therapy. So we recommend that based on your history and physical, if there's evidence to suggest sleep apnea in a patient with pulmonary hypertension, a sleep study should be done. Now let's look at the labs in Rita. The ANA was negative. The echo did show evidence of pulmonary hypertension. There was no shunt on the TEE study. The VQ scan was normal. PFTs were normal, including the diffusion capacity. The 6-minute walk test did reveal a reduction in her walk test. The walk test, usually most people can walk about 400 meters in 6 minutes. Most of you and I here who are normal. So you can do about 400 meters if you're okay. She did not desaturate, which is important. Now the next step we would do in this situation is a right heart cath. The right heart catheterization is the diagnostic gold standard for pulmonary hypertension. It's an extremely important step. Without it, one cannot make a diagnosis definitively of pulmonary hypertension. In addition, no pulmonary arterial hypertension specific therapy should be initiated without a right heart cath because of the potential for adverse effects from the medications that are used for WHO Group 1 pulmonary hypertension therapy. And what this slide basically shows you here is that when you have pulmonary hypertension, pre-capillary, and this is called the capillaries, post-capillary is related to left heart disease, valvular disease, and what you'll find is an elevated pulmonary capillary wedge pressure, normal PVR. Sildenafil, any of the drugs that we're going to be talking about later, should not be used to treat pulmonary hypertension from this. You should treat the underlying disease. If they have pre-capillary pulmonary hypertension, and I went too far. If you have pre-capillary pulmonary hypertension, then one must still rule out other diseases such as lung disease or CTEPH. And what you'll find in this group is a normal pulmonary capillary wedge pressure or left ventricular end diastolic pressure, and an elevated pulmonary vascular resistance as we talked about earlier. In Rita, this is the right heart cath, and what you can see here is that the right atrial pressure is elevated. The mean pulmonary, the pulmonary artery pressures are markedly elevated with the mean of 63. Remember we said 25 was a cutoff. The left ventricular end diastolic pressure was essentially normal. Oxygenation did not change significantly. Cardiac output was normal, and the PVR was markedly elevated. Now in this group, in pulmonary arterial hypertension, we recommend doing vasoreactivity studies to determine if the patient are calcium responsive. And in this patient, the patient was not, so that we would start the patient on medications, not calcium channel blocker agents. And they'll talk about that in just in a minute. Now, so again, the importance of the right heart cath is differentiated between pulmonary venous hypertension from pulmonary hypertension and determine if the patient has evidence of pulmonary arterial hypertension. And this again is represented by elevated pulmonary vascular resistance, normal left atrial pressure, and this would be considered group 1. Again, group 2, you're going to see elevated in the pulmonary wedge pressure, the left ventricular and diastolic pressure will be elevated. And these is a different category. And the last category we'll let you know about, there are patients who have increased cardiac outputs. And in these patients, they can have pulmonary hypertension because of increased blood volume within the pulmonary circulation itself. This does not require therapy, any pulmonary vasodilator therapy. It requires treatment of the underlying disease. Now, lastly, before I finish, who should be screened for pulmonary hypertension? Patients who have systemic sclerosis and a familial history of heritable form of pulmonary arterial hypertension. Optimal screening interval has not been adequately studied, but most experts in the international conference recommends that annual screening be done in these patients. Any patient who's being considered for liver transplantation should also be evaluated for pulmonary hypertension because the prognosis is extremely worse in those patients who have evidence of portal pulmonary hypertension undergoing liver transplantation. So I just want to summarize here, this is the Nice pulmonary arterial diagnostic algorithm. If the signs and symptoms and history are suggestive of pulmonary arterial hypertension, an echocardiogram should be done to screen the patient for pulmonary hypertension. If you've gone through an extensive workup, the ultimate diagnosis is made by doing a right heart catheterization. In summary, in these patients who have dyspnea, you should have a high index of suspicion for pulmonary hypertension, especially in those patients who have asthma without abnormal PFTs, especially if the symptoms are persistent despite therapy. A thorough diagnostic evaluation, as we talked about, should be done in the patients. One must exclude thromboembolic disease. You should evaluate the patient for potential causes, contributing issues, and a right heart catheterization should be required prior to initiating therapy. Baseline functional evaluation should include 6-minute walk testing in your patients. This is from the Pulmonary Artery Hypertension Association Journal, and I think this summarizes what I talked about. If you don't have a right heart cath and you don't do a VQ scan, you have not made a diagnosis of pulmonary hypertension in your patient. And I'll end here. This is a quote from Oprah Winfrey. I sometimes read cartoons, and I thought this was kind of funny. The biggest adventure you can take is to live the life of your dreams, and hope that all of y'all today will live a life beyond your wildest dreams. Thank you for your attention. Post-test. So this is a post-test. A 55-year-old man has a 2-year history of fatigue and daytime sleepiness. He has dyspnea on exertion for the past year, especially after walking upstairs on an incline. He does not smoke cigarettes. He has hypertension and has taken only losartan. On physical exam, vital signs are normal. He is obese, BMI of 38. He has a short, thick neck, circumference of 20 inches. There's increased intensity of P2. Chest X-ray is normal. Pulmonary function tests are normal. Transthoracic echocardiogram shows evidence of right ventricular hypertrophy and mild pulmonary hypertension. A lung VQ scan is normal. Which of the following is the most appropriate management for this patient? Lung transplantation, polysomnography, right heart catheterization, nocturnal continuous positive airway pressure, or sildenafil? You may answer the questions now. So, I must have confused you. So in this patient, the patient did have pulmonary hypertension, but he had signs and symptoms of sleep apnea. And so the recommendations in this patient would be to do a polysomnography first, because based on the history and everything, I would not do a right heart cath at this point, because more than likely the cause of the pulmonary hypertension was his obstructive sleep apnea. And what we do in clinical practice in this situation is that we would treat the patient with polysomnography, reevaluate the patient to see if there's still evidence of pulmonary hypertension, then do additional workup at that point. But we would treat the underlying disease first, not go ahead and do a right heart cath in this case because it was only mild disease. So the answer to this would be 2, polysomnography. I'm sorry I confused you all. Next question. A 32-year-old nursing student has a 2-year history of progressive dyspnea. She was treated for asthma with the albuterol inhaler, but her symptoms continue to worsen. Her medical history is otherwise normal. She is a non-smoker. Currently, she is not taking any medications. On a physical exam, vital signs are normal. BMI is normal. P2 is prominent. A grade 1 to 2 of a holosystolic murmur that increases with inspiration is heard best along the left sternal border. Workup includes serologic studies and lab tests, which are all within normal limits. Chest X-ray reveals prominent central pulmonary arteries, otherwise clear lungs. Pulmonary function tests reveal a mildly reduced DLCO without evidence of airway obstruction or decreased lung volumes. Transthoracic echocardiogram shows normal LV size and function. A dilated right ventricle and an estimated right ventricular systolic pressure of 45 millimeters of mercury. And lung VQ scan is normal. Which of the following is the most appropriate diagnostic test to perform in this patient? Pulmonary angiography, sleep study, transesophageal echocardiography, right heart catheterization, or high-resolution CT scan of the chest. You may now answer.
Hip, hip. Hip, hip.
All right, well, almost got 70%. So that is the right answer. So you did learn something. In a patient like this, she had no evidence of anything else that could possibly cause her pulmonary hypertension. It's a young woman. And so the most likely diagnosis is pulmonary arterial hypertension. The best way to make the diagnosis in this patient is a right heart catheterization. Thank you very much.